All right, so we're going to go ahead and get started with our first talk. It is my distinct pleasure to introduce our first speaker, Dr. Sarah McClanahan. Dr. McClanahan completed her medical degree at the OSU College of Osteopathic Medicine and her residency at the University of Oklahoma School of Community Medicine. She joined the faculty at OU School of Community Medicine, where she served as the medical director for the OU Impact program from 2017 until 2022. During that time, she also worked with the Mental Health Association's medical team and provided psychiatric consultation to the Sooner Health Access Network. She has a special interest in community medicine and serious mental illness. She carries board certification in psychiatry and obesity medicine and is certified in community psychiatry from the American Association of Community Psychiatrists. She currently serves as the executive director for behavioral health for St. Francis Health System. Today, she will be speaking on antipsychotics for primary care. Please join me in welcoming Dr. Sarah McClanahan.
Good morning, everyone. Thank you for having me. It's nice to join you. Today we're going to talk about antipsychotics. I'm going to go over a very brief overview. I hope that it's not too much, but this is a lecture similar to what I would give our interns as they're starting out in psychiatry when I was at OU. So I have nothing to disclose. There we go. Here are our objectives today. So we're going to talk about the basic mechanism of action of antipsychotics, which is important to help you understand the potential side effects that you might see in individuals that you're taking care of that might be taking them, or if you end up prescribing them. Review the indications and use of antipsychotic medications. We're going to primarily focus on using antipsychotic medications for psychosis today. And describe the major side effects for these medications, how to monitor for the side effects, and how to treat the side effects. So first of all, the mechanism of action. So D2 receptor antagonism is the primary mechanism that we think of for antipsychotics traditionally. Our initial antipsychotic that was found was chlorpromazine, and this was actually found by accident. It was a medication that was being used to treat nausea, and it was shown that in individuals that were psychotic, that received this medication, those psychotic symptoms lessen. And so our first generation antipsychotics, this is the primary mechanism of action that we have, that they block D2 receptors, decrease psychosis and those types of symptoms. Our second generation antipsychotics that were developed later, and we're going to focus on just two of these mechanisms here that have D2 antagonism and a 5-HT2C antagonism, and some have partial agonist activity, and so we'll go through how that affects the medication. So let's talk about our dopamine pathways, a little trip back down to neuroanatomy in medical school. So in your mesolimbic and your mesostriatal pathway, the dopamine in this pathway is what's responsible for reward. When I'm thinking in terms of addiction or those types of things, when you have your favorite food, so for me it's chocolate cake. I take that chocolate cake and dopamine goes off in this pathway, and it reminds me of the fact that my grandmother made chocolate cake and I loved her chocolate cake. And so it gives us pleasure and reward. In individuals with schizophrenia, this pathway is actually hyperactive. And so that leads to psychosis, hearing things that aren't there, seeing things that aren't there, feeling paranoid. And that's what we're trying to treat. So by blocking dopamine in that pathway, we have a reduction of the positive symptoms. So things that are there that should not be there is a positive symptom. Auditory hallucinations, visual hallucinations, paranoia, those types of things, they shouldn't be there. We refer to those as positive symptoms. And when we block dopamine in this pathway, we decrease those symptoms. That's what we want. But as I just said, this pathway is also responsible for reward. And so a side effect that we get by blocking dopamine in this pathway is what we call secondary negative symptoms. And negative symptoms are things that are not there that should be there. So drive, motivation. So we see patients develop apathy, anhedonia. They're not wanting to really get up and do things. These behavioral type symptoms that are causing them to be withdrawn. So the mesocortical pathway is also a dopamine pathway, and you have two different targets in this pathway. And we know that the mesocortical pathway is responsible for our cognitive and executive functioning. And this pathway is still under study in individuals with schizophrenia and psychotic disorders, but it's thought that this pathway is hypoactive. So the dopamine in this pathway is not what it should be. So this is part of what is responsible for that blunted affect, looking flat, that anhedonia, that apathy that's already there. But now when we add dopamine blockade to the system, we're making that worse. So you're going to have an increase in those symptoms. So the tubuloinfundibular pathway, this is the pathway that goes up to produce prolactin and is responsible for lactation. And so dopamine typically inhibits this pathway from producing prolactin and inducing lactation. But when we block dopamine, we don't have that anymore. And so this can lead to increased prolactation or increased prolactin, leading to galactorrhea as a side effect of these medications, and can also cause amenorrhea in women, gynecomastia in men, and so that's where that side effect comes from. And then the nigrostriatal pathway, we're most familiar with this when we think about movement disorders such as Parkinson's and Huntington's disease. When we block dopamine in this, we can have a couple of different things happen, and we're going to talk about these more in depth in a moment, but I'm going to touch them now. So we can have akathisia, which is this restlessness. So you might see your patient pacing like this. They can't stand still. They're in your exam room and they're standing up and they're walking around and they're tapping their foot. Typical Parkinson type features, so drug-induced Parkinson, so that shuffling gait, pin rolling tremors, masked faces, dystonias. And then over time, we see that as we block dopamine in this pathway, we have an upregulation of receptors, which leads to tardive dyskinesia. And so this is this irregular movements that happen. So our first generation antipsychotics, the way I like to look at these is their potency of D2 receptors. So we like to have D2 receptors. We know if they're saturated at 80%, that's probably going to target psychosis. Anything above that is going to produce symptoms. And so this table is ordered in increasing order of D2 blockade. And so prolixin and fluphenazine and haloperidol are our most potent D2 receptors, and so those are typically the ones that are going to be used most often to treat psychosis. So we know that if they have an increased higher potency for D2 receptors, you're going to have an increased side effect for extrapyramidal symptoms. And as the top ones on this list have increasing anticholinergic side effects, so we think about these causing hypotension and weight gain. These two in high dose can cause those extrapyramidal symptoms. To even our top ones up here, like thorazine, can cause extrapyramidal symptoms. So haloperidol and fluphenazine, I talked about these two because these are the ones that in my practice at OU with the impact team that I would use most commonly if I was going to use a first generation antipsychotic to treat folks with serious mental illness. They're very potent, which means the patients are at high risk for developing extrapyramidal symptoms. Both come in long-acting formulations, and both also come in short-acting formulations. So the long-acting formulations we'll touch on in just a minute, but the short-acting formulations you can use to treat acute agitation. We'll typically use that in the hospital for somebody who's acutely agitated. And so they also come in these long-acting injections. FDA indications are for schizophrenia. For haloperidol Haloperidol, the decanoate, you're going to dose that at 10 to 15 times the oral dose. So anytime we're using a long-acting injection, we want to make sure that the patient tolerates it and isn't going to have any reaction to it. And with haloperidol decanoate and fluphenazine decanoate, you need to make sure that you have started the patient on an oral dose and have had some control of their symptoms, so you know how to dose that medication, because the injection dose is going to be based on your oral dose. And with fluphenazine decanoate, it's going to be about 1.5 times your oral dose for your injection. So let's talk about second-generation antipsychotics. So when you had the first-generation antipsychotics, because most of them were so potent at blocking D2, and they blocked the D2 receptors throughout the whole system, we wanted to find ways, how can we deal with the side effects that are happening from this potent D2 blockade? And so second-generation antipsychotics were started. This is set in order of increasing metabolic side effects. So at the top, these are less likely to cause weight gain to the most likely to cause weight gain. And so this adds a 5-HT2C antagonism, and we know that unregulated serotonin can participate in these dopamine pathways and lead to, hallucinations. And so this 5-HT2C, what it does is it interacts, it acts in the system to block, to decrease, in these other pathways, to decrease the positive symptoms. It also acts in the other pathways that we were talking about to increase dopamines in the nigrostriatal pathway and our mesocortical pathway to alternate those side effects. So you have decreased risk of EPS. It's been shown to help with those negative symptoms and the cognitive effects that you see. So I just wanted to touch on our second-generation antipsychotics a little bit, because these are the ones that I felt as primary care physicians you probably would be using the most often in your practice. So aripiprazole, FDA indications for schizophrenia, bipolar disorder. It can be used for maintenance and acute treatment of manic or mixed episodes, depression as an adjunct treatment, and autism-related irritability in children and adolescents. Abilify is unique because it is a D2 5-HT partial agonist. So it doesn't have that full antagonist blockade, and it has a lower side effect profile, but it does have a higher incidence of akathisia. One of the off-label usages that you can use for this is reducing hyperprolactinemia. So in folks that are having problems with hyperprolactinemia from their antipsychotics, you could potentially switch them to Abilify, and sometimes we'll augment with a little bit of Abilify to decrease those side effects. It is also available in injectable forms, Abilify Maintena and Abilify Aristato and Initio, and we'll talk about those here momentarily. With this partial agonist activity, sometimes, depending on how long the individual has struggled with psychosis, it may not have as big of an effect in treating the psychosis. Lorazepam or Latuda. This is indicated for schizophrenia or bipolar disorder. This medication must be taken with at least 350 calories of food for it to work, and if they're not taking it with food, it will not work. And so if you have patients that are on this, I would ask them, if they come in and say it's not working, make sure that they're taking it with food. This is one of the downsides of this medication when you're working with a seriously mentally ill population, is making sure that they understand to take that medication with food. Same with the ziprasidone or Geodon, indications for schizophrenia, mania, mixed episodes of bipolar maintenance, and acute agitation. This you have to take with at least 500 calories of food. It's also available in a short-acting injection for acute agitation. There's also a black box warning on Geodon, particularly for the QT prolongation, But you can see that across all medications in this class. Again, it's a great medication for treating bipolar disorder, folks that haven't had multiple episodes. It's a great medication to treat that. But again, it's not gonna work if people don't eat food with it. In a moment, we're gonna talk about side effects. So we know that our antipsychotics do have side effects of metabolic syndrome and weight gain. And so it's also important if you have patients on the Latuda, lurasidone, or the ziprasidone, that you're helping them understand what 300 to 500 calories looks like and what you want them to eat for that 500 calories. I remember one of my clinic patients when I was in residence, she was like, oh, I'm eating bean burritos every night with my Geodon. And so we had to talk about what is a healthy 500 calorie to eat with your medication. Acenapine or Saffris, FDA indications for schizophrenia, mixed or manic episodes of bipolar with or without psychosis. This is available in a sublingual formation. I've heard patients say that they like the taste, they don't like the taste, but it's important that they don't eat or drink for 10 minutes after taking it for it to be effective. It also has some sedative properties, so I like to use it when patients are, I'm needing to get them to sleep. Sorry. Iloperidone is indicated for schizophrenia. So with this medication, it's more prone to causing orthostatic hypotension. So there's a specific dose titration that you have to use for that. It does come in a titration pack, but sometimes insurances don't cover the titration pack. And so you can follow the titration and send it in individually like that if the insurance won't cover it. Paliperidone, this is Dr. McClanahan's favorite antipsychotic, and I'll talk with you more about why later, but it has indications for schizophrenia. It's prone to hyperprolactinemia. So if you're gonna have an antipsychotic that's gonna cause somebody to start lactating, it's gonna be paliperidone or risperidone. It's active metabolite of risperidone. It comes in 3 forms of long-acting injections that we'll talk about in a minute. Risperidone, indications for schizophrenia. It's available in sublingual forms, which is great. I like to use that for acute agitation, or if you have a patient that has difficulty swallowing, or if you're not really sure if they'll take the medication, you can have family, if they're at home, watch them dissolve it under their tongue. We do that a lot of times on our inpatient units. Again, it's very prone to hyperprolactinemia. Doses that are higher than 6 milligrams a day, total daily dose, make it act like a typical antipsychotic. So as you increase that dose of risperidone past 6, you're gonna start to see more EPS and those types of side effects that you saw with the first generation. Risperidone Consta is one of the injections, and we're gonna have a slide on these, so we'll go back and talk more about these momentarily. Quetiapine, Seroquel, it comes in a long-acting and an extended-release formulation. FDA indications for schizophrenia, bipolar, can also be an adjunctive treatment for monodepression. The IR formulation can be abused potentially and does have a street value, so you need to potentially use caution when you're prescribing that. If you use the XR formulation, I typically will sometimes try to dose that in the earlier evenings instead of right at bedtime, because it helps really kind of target getting them to sleep when they're ready to sleep and doesn't have the side effects in the morning of them feeling tired or sedated. Less likely to cause EPS. It's a medication that you can use in your Parkinson's folks that are experiencing psychosis. And then you want to titrate it slowly because it can lead to orthostasis. Typically more in our geriatric population, we want to go up on that slowly to make sure that we're not causing them to get dizzy and fall down. Clozaril, actually this might be my favorite antipsychotic. Invega is my favorite antipsychotic for stuff that goes to injection, but clozapine is a wonderful medication. It's used to treat schizophrenia, treatment-resistant psychosis. It comes with its own share of difficulties and hard times potentially prescribing it because you have to register with the clozapine REMS. It requires frequent blood monitoring. The biggest side effect that we worry about with clozapine is agranulocytosis. And so to watch out for that, you have to monitor with the CBC for the first 6 months weekly, second 6 months every other week, and after 12 months, monthly. There's also risk for different cardiomyopathies, and so we want to get at baseline, I like to try to get CK, CKMB, in addition to all my other baseline labs I'm gonna get with prescribing an antipsychotic. But clozapine is a wonderful medication. When I was at OU, we had a patient on the PAC team who was started on clozapine. He was very sick. He was not able to work. He was living with his mom, but his symptoms resolved with clozapine. He was able to graduate from OSU with a master's degree and is working full-time. And so being able to catch psychosis and treat it early, and you have someone that's a good candidate for this, can be life-changing for individuals that are able to go about a quote-unquote normal life. But it is a hard medication to use because of the monitoring requirements. It's hard to get people to agree to have a blood draw daily or weekly. They might have transportation issues with that. But this is a life-changing medication. So it is very prone to weight gain and sedation. And so that's another reason why people don't stay on it. But if you can get past that, it's a great medication. And it's also been shown to reduce violence and suicide in individuals with schizophrenia. It's the only medication that we know of right now shown to reduce mortality from suicide in individuals with schizophrenia. So individuals that have had multiple suicide attempts, so the individual that I was telling you about had multiple suicide and self-harm attempts, and that was probably part of the reason that he was started on that. He was started on it before I got him. And also violence, and so folks that are prone to violence when they're psychotic, it's been shown to reduce those behaviors. Olanzapine or Zyprexa, FDA indications for schizophrenia and bipolar. You can pair it with fluoxetine to treat bipolar depression, and that's also a wonderful medication. It comes in a short-acting injection for acute agitation, but if you're giving an IM injection of Zyprexa, you cannot give lorazepam with it. It can cause negative side effects, and so we don't want to combine those in the injection form. And it also comes in a long-acting injection called Relplev, but it's not typically prescribed due to monitoring requirements. It's been shown to increase the risk of cardiac issues after giving it, and so typically people have to be on a cardiac monitor with a crash cart, and so not a lot of clinics are equipped with that equipment, so it has not been a medication that has been used long term. It also comes in a sublingual form, which is nice to use for maintenance for people, but also for acute agitation. So let's talk briefly about long-acting injections. Long-acting injections are also a wonderful thing that has been brought to the field of psychiatry. I understand as primary care, you may not be prescribing these, but you're probably gonna be taking care of folks that are on these medications. These medications are great for people who forget to take their medications and they end up back in the hospital. We know that the more episodes of psychosis or mania that end somebody in the hospital, that decreases their baseline level of functioning. And so we want to try to prevent those episodes. I'm in favor of, even in that first episode of psychosis, if I know that this person has schizophrenia, once we get them through, to put them on a long-acting injection, because I know that it's gonna prevent them from having episodes later on. It's gonna improve their quality of life, improve their health. So we'll talk briefly about these. Abilify Maintena, this is long-acting aripiprazole. It's indicated for schizophrenia and bipolar disorder. Comes in 2 doses, 300 and 400 milligrams. The 300 is typically recommended for folks with, sometimes in our older population, and folks with renal dysfunction. There is a titration requirement with this. You have to continue them on their oral dosing for 21 days after you give that first injection. I like to continue them until I give them their second injection, just because that gives me a little bit more cover when I'm prescribing this. And then it doesn't muddy the waters of if I stopped their oral at day 21 and then I see them at day 28 for their injection and they're still kind of psychotic, it doesn't make me guess if the Abilify is working or not. Abilify Aristata is also indicated for schizophrenia. This comes in a variety of dosing, and this allows us to extend that injection out 2 months. So Abilify Maintena is every 4 weeks. The Abilify Aristata, that highest dose, can go to every 8 weeks. And so again, this is helping this patient population. They may not want to get an injection every 4 weeks. It extends that out a little bit. You do have to do a titration with it, but in the last couple years, they've come out with another form that you can give with it. It's called Abilify Initio, and this is how you can load people with the Abilify Aristata. So you base your dose of your Abilify Aristata, decide what your maintenance dose is going to be. You give that, Abilify Initio, plus a 30 milligram tablet of aripiprazole, all on the same day, and you don't have to continue a titration phase. You don't have to continue any oral. They're loaded. The medication is in their system ready to go until their next injection is due. Now on to why Invega initially was my favorite. Because when you give Invega Sustenna, you don't have to continue their oral medication. You can stop it. And so if you think about why we're giving a long-acting injection, we're giving a long-acting injection because somebody is not compliant with their medication. And if we have to make sure that they take the oral form of their medication to have this shot effective, then it may not work as well. And so the Invega Sustenna is an every 4-week injection. So you're going to give, to load it, you're going to give 234 milligrams on day 1. A week later, you can give 156 milligrams IM. And then 5 weeks after that first dose that you gave, day 1, you're going to give your maintenance dose. And this is based on where they were orally, on what dose of oral Invega that they were on. And you don't have to continue any oral overlap with it. Invega Trinza is a 3-month dosing injection that they came off. The dosing on this is based off of their previous Sustenna dose. So using a medication like Invega or Trinza, you want to make sure that their symptoms are stabilized on Invega Sustenna first. And then in the last probably 2 years, they've come up with Invega Hafyera, which is every 6 months. And then we have Risperdal Consta. This has FDA indications for bipolar, schizophrenia. It must be refrigerated. So depending on where their patient's coming from, if they're homeless, they're not going to be able to refrigerate it. So that's a thing that we have to think of. And with the Invega Consta, you have to have an overlap of 3 weeks. And then in recent years, they've come out with Risperdal Perseris. The nice thing about this medication is you don't have to have your PO overlap, and it's sub-Q. And so some patients don't like having the IM medication, and they prefer a sub-Q. And it's only every 4 weeks as opposed to every 2 weeks. So here's the general guidelines that I recommend when prescribing antipsychotics. So the APA, from their treatment recommendations for schizophrenia, recommend that all individuals with schizophrenia be treated with an antipsychotic medication. I typically, if it's a patient brand new to me presenting with psychosis, like to start with the second generation antipsychotic. And we've talked about that because of the side effect profile is less with these medications than it is with our other medications. After failure of 2 antipsychotics, you can try clozapine. Consider using a long-acting injection earlier, not waiting until you've run through all the medications. Because again, we want to prevent the number of episodes that individuals are having. So side effects of antipsychotic medications. So individuals with serious mental illness have a known health inequity. We know that individuals with serious mental illness are dying 15 to 20 years earlier than their age-matched counterparts, and it's from things that are preventative. Things like diabetes, heart disease, cerebral vascular disease. And so as primary care, this is where you can really affect and help people with serious mental illness, because you're the front lines of that and helping the psychiatrist or their team, making sure that we're monitoring for this. We also know that folks with serious mental illness, they're probably missing their workups. And so why is this happening? They smoke. Probably 80 to 90% cigarette smoke rate in this population. 50% other substance use rate in this population. Part of this is thought to be due to that it helps counteract those side effects. So some of the antipsychotics that we have, they're metabolized through pathways that the hydrocarbon smoke from cigarettes and marijuana, it enhances that, so it decreases the rate of the antipsychotic, and it helps them not have as many side effects. So they smoke. They have a sedentary lifestyle. Stigma. So oftentimes folks with serious mental illness, they are not going to seek care. They may not want to come into the office. Maybe they've been brushed off as, oh, well, that's Joe. He's always psychotic. He doesn't know what he's talking about. They may not feel comfortable seeking care in your office. They may have symptoms. They may be sitting in your office responding to internal stimuli. Their access. A lot of the folks that I took care on the PAC team, they didn't want to go to primary care, and so I became their primary care doctor with the assistance of our primary care consultant, because they didn't want to go sit in the office. It made their symptoms worse. It made them scared. They may not have transportation. If they're not with a PAC team, they don't have people that can pick them up and take them to appointments. And medication. So the medications that we're prescribing, we've talked about, can produce metabolic syndrome. I'm not going to talk to you guys about metabolic syndrome because I think that primary care is probably more of an expert than I am. But they do have greater risk for developing metabolic syndrome, especially folks that are on second-generation antipsychotics. So for the treatment of metabolic syndrome, we want this to be a multimodal approach, potentially considering antipsychotics that have a lower side effect profile if we can switch them. A multi-layered approach. So using medication, metformin has been a medication that's been used to treat antipsychotic weight gain. Lifestyle modification with diet and exercise, and making that in simple forms that your patient can understand, because go back to that mesocortical pathway that is already downregulated in somebody with schizophrenia, and now they have an antipsychotic, so it's further downregulated. And so making sure that as you're making those diet recommendations and those lifestyle recommendations, it's at a level that your patient can understand. So take-home points: screen regularly for metabolic syndrome. With antipsychotics, especially your second generation, you should get blood pressure, weight, lipids, and A1C at baseline, then 3 months, blood pressure and weight at 6 months, and then repeat all of that annually. Extrapyramidal symptoms. So this is on a spectrum. Dystonia typically starts within hours of receiving an antipsychotic, with tardive dyskinesia taking months to years after being on an antipsychotic. So dystonia, this typically occurs acutely over hours to days after starting antipsychotic, so typically torticollis. You'll see those kind of different dystonic reactions. We typically treat this with administration of an antimuscarinic agent or an antihistamine such as diphenhydramine, and these can reverse these side effects rather quickly. Akathisia, we talked about this earlier. It's described as this inner restlessness. Remember, your patient's just going to be pacing your office like this, and they're not going to be able to sit still, and they're going to sit up, and they're going to go back and forth like this. They might be tapping their foot. This can lead to insomnia, can lead to violence, because they want to do anything to get out of that inner restlessness. And so what I'll often ask people, if they come in and they say, hey, Dr. McClanahan, I'm really anxious. I'm like, well, tell me more about that. Do you feel like you got butterflies in your stomach, or are you worried about something? And oftentimes they'll tell me, I feel like I have butterflies in my stomach. So they're at risk for violence, they're at risk for self-harm, and they're at risk for suicide. And so it's really important that we diagnose and treat this early. Try lowering the offending agent, if you can. Beta blockers, antimuscarinic agents, and benzodiazepines are the treatment of choice. Drug-induced Parkinsonism. This looks just like Parkinsonism, except you have antipsychotic on board, and it typically develops symmetrically, whereas Parkinson's is an asymmetric development. Tardive dyskinesia. This is typically late onset, months to years after starting an antipsychotic medication. They have irregular movements. It's non-rhythmic. And so when diagnosing this, you want to consider the duration of the antipsychotic that they've been on, plus the type of antipsychotic that they've been on. So any first generation exposure of an antipsychotic increases that individual's risk for developing tardive dyskinesia, which is why we want to start with a second generation antipsychotic. Oftentimes it's irreversible. You can potentially improve the symptoms, but once it's there, we're not going to be able to get rid of it. Lower incidence is seen with clozapine, quetiapine, and olanzapine. Avoid anticholinergic meds. So a lot of times when you're seeing side effects, you might see something that looks like a Parkinsonian tremor or those types of symptoms. So you want to throw an anticholinergic at that, and that's going to worsen their tardive dyskinesia. And so in 2020, there was a Delphi panel that came out looking at the American Academy of Neurology and the American Psychiatric Association, and they recommend that individuals with tardive dyskinesia, regardless of severity, be treated with VMAT2 inhibitors. So take-home points for EPS, evaluate for EPS at every visit. Note the timing of the symptoms compared to when the medication was started. Dystonia, we're going to treat with diphenhydramine, benztropine, or trihexyphenol, beta blockers for akathisia or benzodiazepines, Parkinson, benztropine, amantadine, trihexyphenol, and with tardive dyskinesia, we're going to use a VMAT2 inhibitor, and we're going to try to avoid those other medications. Just one second. I have a video that goes over briefly what all four of these look like.
With Nurtec ODT, I can treat and prevent my migraine attacks all in one.
Don't take if allergic to Nurtec. Allergic reactions can occur even days after using. Most common side effects were nausea, indigestion, and stomach pain. Talk to your doctor about Nurtec today.
Welcome back. In this video, we'll talk about the side effect of antipsychotic medications. There are 4 main side effects that are present in all antipsychotics, or any other medication that blocks the action of dopamine. Starting with acute dystonia, which occurs very quickly, usually in hours or days. This is characterized by sustained muscle contraction, and this can affect any muscle in the body. The question normally mentions a patient who is taking antipsychotic medication, and his eyes are closed shut and he can't open them, or his mouth is wide open and he can't close it. The treatment for dystonia is benzotropine or first-generation antihistamines. like diphenhydramine. Next, we have akathisia, which takes days to develop. It's characterized by restlessness. So the patient would be unable to sit still. They would have to keep moving around or maybe keep moving their legs. It's quite the opposite of dystonia. We treat it with 3 Bs: beta blockers, benzodiazepines, and benzotropines. If the patient is taking antipsychotics for many weeks, they can develop Parkinsonism. Because as we know, the pathophysiology behind Parkinsonism is the lack of dopamine, and antipsychotics blocks dopamine. Presentation-wise, expect a wide range of Parkinsonism symptoms, ranging from tremors to rigidity to bradykinesia, and etc. In this case, we don't stop the antipsychotic medications, but instead we give the patient benzotropine or amantadine, which replenishes the brain reserve of dopamine. And if the patient is taking antipsychotic for many months, at least 6 months, they can develop tardive dyskinesia. It causes a repetitive contraction of any muscle of the body, characteristically lip smacking. We treat it with the monoamine oxidase inhibitor, vilbenzine, tetrabenzine, or clozapine. And here's a small quiz.
And if you notice in that picture of the tardive dyskinesia, it's irregular, so it's not happening like a regular Parkinsonianism tremor, and so that's how you can tell the difference between the two. And that's all I've got. Thank you guys for listening, and I appreciate it. Yes, do we have questions? Yes. Yeah. I typically refer to my internal medicine colleagues where that is significant and looking. The question was about treating hyponatremia. So I'll typically work in conjunction with my internal medicine colleagues on treating that. It depends on if it's risen to the level that we need to get that patient into the hospital to treat that. I try to get that antipsychotic, even if we have to stop it temporarily, back on board because we don't want to exacerbate their psychosis. I had one case when I was in medical school of somebody that was hyponatremic from their antipsychotic, and they had initially pulled it off, but then we started their antipsychotic back while they clinically treated the hyponatremia. So the question was, how long do you continue the medications? And so if it's for a diagnosis of bipolar, schizophrenia, schizoaffective disorder, these diagnoses are lifelong. And so I typically continue. If you're going to look at discontinuing, I would only do that under the supervision of a psychiatrist. You might be able to, so a lot of times when somebody has an acute psychotic episode, we have to use higher doses to get the symptoms under control. And then we can try to slowly lower it to a lower dose, the lowest effective dose, to keep symptoms in check without causing symptoms to return. So I'll try to do that some clinically, but I'm typically not taking these folks off of their antipsychotic. And sometimes what I'll do with those individuals, if I am able to lower it, if they have another episode, then we just bump back up to where we were until the episode clears. So the question was about treating drug-induced psychosis. I mean, potentially, yes. It can help resolve those symptoms acutely, but if they're going to continue to use the medication, that's not going to mask that. When I see folks in the hospital, if I have a concern that they've come in for drug-induced Psychosis, I try to not start an antipsychotic regularly because that muddies the water. I may have one on as needed for psychotic agitation, but I want to see, do they clear after the substance is out of their system, or does the psychosis continue? And we do see with long-term substance use, especially marijuana, in young adolescents, young adults, highly concentrated marijuana, that can lead to maybe initially that psychosis was drug-induced, but they have used so much now they've stepped over into now having a primary psychotic disorder, and then I'm going to treat that presentation long-term with an antipsychotic. Does that make sense?
Does it need to be like is it a fat soluble, so it needs to be a higher fat?
That I don't know for sure. Typically, I just recommend, we've recommended like some peanut butter or things like that. It doesn't necessarily have to be a highly fat soluble, to my knowledge. Do I prefer a beta blocker for akathisia? Kind of depends on where I'm treating it. If I'm going to treat akathisia long-term, probably prefer a beta blocker. If I don't have a concern for an ongoing substance use or diversion and it's really severe, I'm probably going to start with a benzodiazepine, and we'll do a benzodiazepine inpatient initially. And then you have specific beta blockers. Sorry, propranolol. Propranolol for treating akathisia, beta blocker. Excuse me?
Can you use these first line for bipolar?
You can potentially use Abilify or Seroquel, but I don't start there just because of the side effect profile, and I think that Depakote and lithium have better clinical indications and evidence behind those. So it can act like, actually I'm going to let Dr. Bingman answer that one.
Why do I always get the drug questions? So Seroquel has street value to it. So when we look at whether or not something is addictive, a really good way to evaluate that is if someone's willing to pay for it. The value goes up dramatically if you're incarcerated. So it's one of those medications that inmates will try to get. And we think that it does provide some sort of mild euphoria, but it's also a sedating medication. So it's just like a depressant, like maybe an opioid or a benzodiazepine. Now, don't get me wrong, no one's at a party on a Friday night like, hey, where's the Seroquel, right? But if you don't have access to other things, and then people who are on it really, really like it, and they don't want you to touch their Seroquel, suggesting that there's some sort of dependency. When I was medical director at 12 and 12, the facility here in Tulsa, the treatment facility here in Tulsa, we put it on our banned medication list because it was one of those things that people were just always seeking, and it's a substance that they can use to feel different than they do right now, which is something we want to avoid.
Also, I've seen some people use that when I was on the PAC team, when we'd have people ask for PRN Seroquel, but they were using other medications, and it can be used to come down from things like methamphetamines as well, outpatient. Wait.
Can you comment on any of these meds as far as treating agitation with dementia? Because we see that a lot in the hospital.
Yeah. So the question was about treating agitation with dementia. So typically treating agitation with dementia, there is a black box warning on these medications that it can increase risk for cardiovascular disease. But if you use these, you start low, use the lowest dose you need, and then typically you need to try to taper them off at least every 3 months. So in the hospital, when I work on the consult service here and it's agitation due to dementia or delirium, I'll use olanzapine, risperidone, sometimes Seroquel, or even haloperidol, and you try to use the lowest dose you can. And then after you stabilize them, you should try to taper them off. And if you can, as long as you're having that conversation with the patient's family, the patient, and you're justifying in your medical record why you're needing to continue that, and you attempted a taper and what happened when you did that, you're going to be fine. Thank you, guys.